The Pickelhaube sign, also referred to as the spiked helmet sign, refers to two entirely distinct clinical entities depending on whether you are looking at an electrocardiogram or an echocardiogram. While both are named for their morphological resemblance to the spiked 19th century Prussian military helmet, their pathophysiology, clinical context, and implications are vastly different. On an echocardiogram, the Pickelhaube sign is a novel tissue Doppler imaging marker strongly associated with arrhythmogenic mitral valve prolapse syndrome. Seen on TDI at the level of the lateral mitral annulus, it manifests as a sharp, high-velocity mid to late systolic spike. By definition, this peak systolic lateral velocity exceeds 16 cm per second. The myxomatous prolapsing mitral leaflets vigorously tug on the posteromedial papillary muscle during mid-systole. This mechanical traction pulls the adjacent posterobasal left ventricular wall sharply towards the apex. Over time, this repetitive mechanical stretch induces localized myocardial injury, friction lesions in the infralateral mural endocardium, and subsequent fibrosis, often visible as late gadolinium enhancement on cardiac magnetic resonance imaging. It serves as a high-risk mechanical marker for malignant ventricular arrhythmias and sudden cardiac death in patients with mitral valve prolapse. It frequently coexists with profound mitral annular disjunction. On a 12-lead ECG, the spiked helmet sign is a rare and ominous repolarization abnormality most commonly seen in critically ill patients, typically without an underlying acute coronary syndrome. It is characterized by an upward shift of the baseline before the QRS, a slurring or notching J-point elevation, and a subsequent downsloping ST segment elevation that merges into a wide T wave or TU wave inversion. It is most frequently observed in the inferior leads 2-3 AVF, but can also appear anteriorly or laterally. The exact mechanism remains debated, but it is typically provoked by catastrophic non-cardiac events such as acute abdominal emergencies like bowel perforation, acute gastric distension, severe intrathoracic pressure overload like tension pneumothorax, or acute intracranial pathology. These events may trigger a massive sympathetic surge or induce severe electrolyte shifts that alter inward or outward transmural potassium currents, leading to profound repolarization gradients. Spiked helmet sign is a harbinger of imminent lethal ventricular arrhythmias like ventricular tachycardia or ventricular fibrillation, and carries a very high short-term mortality risk.